Hello, this is Sandra Hurst, and this is a Doctoral of Nursing Practice presentation on improving interventions on cardiovascular disease and diet, a policy incentive analysis. The agenda will be history of USDA farm bills, the Food Insecurity Nutrition Incentive Program and analysis, and cardiovascular disease impacted by poor diet. The history and progression of the United States Department of Agriculture as the USDA farm bills. The USDA had enacted over a dozen bills since 1933, and the link that you see here in this slide is available to view in the description box. Referred to as the Agricultural Adjustment Act of 1933, the first farm bill of the United States, the purpose was to decrease crop surplus and increase crop prices. Due to war and the Great Depression, crop prices dropped significantly that impacted farmers' incomes, which initiated fair crop pricing policies by the Act. The Agricultural Adjustment Act of 1938 established crop insurance to support farmer income. The Agricultural and Consumer Protection Act of 1973, after several bills were moved forward, was considered the first omnibus farm bill to include food-assisted programs. After 1964, the Farm Bill included food-assisted programs, such as the Food Stamp Act of 1964 that was amended in 1977 to increase the criteria. And then it was renamed as the Supplemental Nutrition Assistance Program, known as SNAP, in 2008. And for those who remember how the Food Stamp Act in the earlier days was, they were actually stamps. The recipient would get the stamps every month and then use that stamp for whatever amount of food that they need. They were valued like dollar bills, like 5, 10, 15, 20, etc. However, later until the act, like maybe like until up until like the late 90s, the recipients were able to sell these stamps under the black market that enabled them to obtain purchase of non-foods, including drugs. And then, and as I said, right around the late 90s into the early 2000s, they changed that the stamps into the electronics benefit transfer card. It's like a debit card now, and each recipient would receive assistance according to their income level. The Food Conservation and Energy Act of 2008, as the 2008 Farm Bill, continued agricultural and food assisted programs for the 2012 fiscal year. Yes, each bill is revised about every 5 years. The Agriculture Act of 2014, known as the 2014 Farm Bill, was established to reform and continue agricultural and food programs for the 2018 fiscal year. It also established the Food Insecurity Nutrition Incentive Program, known as FINI. And then the Agricultural Improvement Act of 2018 renamed FINI as the Gus Schumacher Nutrition Incentive Program as GUSNIP after increased USDA funding that made the program permanent. For those who are not familiar with Gus Schumacher, he was the USDA Undersecretary during the Bill Clinton administration, and also he was the co-founder of Wholesome Wave, which is a countrywide food bank. The purpose of GusNIP. It provides farmers crop and income incentives. It also provides healthy food incentives for SNAP recipients to increase purchases of fruits and vegetables at times of purchase. And this incentive was needed because SNAP would only allow a limited amount of assistance every month. And by the end of the month, the recipients would run out of funds. And that's where the incentives are needed to cover the rest of the month. But they still will only need to buy healthy foods such as fruits and vegetables only that need to be fresh and not processed or canned or seasoned. Problem description and significance. The problem description. Healthcare stakeholders inexpressively addressed chronic disease risk factors by neither prescribing specific preventative care nor healthy diet behaviors. In current research, it mainly discusses the importance of educating the population on eating healthy without addressing promoting healthy diet behaviors. Strokes occur less than every 50 seconds and death occur less than every 5 minutes. The prevalence of cardiovascular disease is about 50%, with much of it contributing to poor diets. Significance of the problem. About 11% of Americans are food insecure. Greater than 10% are SNAP recipients. Diet-related chronic disease has increased faster than tobacco use, in part due to the much more tobacco cessation education, medications, group therapy, and disincentive taxes compared to the very limited interventions for promoting healthy eating behaviors. GusNIP supplements SNAP recipients experiencing poor diet disparities as non-SNAP recipients. Non-SNAP recipients are considered populations that are not participants in the SNAP program because their income level are too high. Also, there are disproportionate prices of more expensive healthier foods and less costly unhealthy foods with limited disincentives. Significance of the problem. SNAP allows recipients to purchase more unhealthy foods than other federal food programs, as much as non-SNAP recipients increased purchase of unhealthy foods due to the expense of healthy foods. In other words, SNAP recipients are allowed to purchase just as much of unhealthy foods as the non-SNAP populations. Quality diet disparities are apparent among minorities whose social determinants of health is negatively affected by environmental and economic issues that are major barriers to healthy diets. Available knowledge. Google Scholar, Elsevier, Science Direct, National Institute of Health, and PubMed databases were used to collect the evidence and to perform the analysis. Themes in literature. The themes in literature were diet-related cardiovascular diseases, barriers to healthy diets, and incentive-driven improved health behaviors. The literature review that's embedded in this slide here to your right will be available upon the instructions in the description box. The summarized findings stated that consumption of Mediterranean diets reduced cardiovascular risk. Dietary approaches to stop hypertension, as the DASH diet, also reduced cardiovascular risk. And other findings were that combining food disincentives and incentives improved diet behaviors. The next set of summarized findings indicated that there were increased intake of incentivized plant foods. There were increased sales of incentivized plant foods. And there were improved health outcomes of healthy food consumption. Rationale, conceptual, and improvement science. The first of the three models here is the eightfold path model, and the rationale is the analysis guide. Burdock and Partashnik 2020 had developed 8 steps for for an effective analysis for a policy proposal. So the first step is to identify the issue. And according to Burdock and Partashnik 2020, when you identify an issue, you want to address the excess and the deficit, such as in this case that healthy foods are too expensive for the average person in the population to be able to maintain a healthy diet. And there are very limited incentives for them to maintain a healthy diet. And the deficit would be that there are too few disincentives for unhealthy, cheaper foods. Step number 2 would be to collect the data of that evidence. And then step number 3 would be to consider alternatives to write the proposal. And number 4 would be to select the criteria involving what is needed to move the policy forward, such as the low income would receive a higher percentage of incentives, while the higher level of income populations would receive a lower percentage of healthy food incentives, instead of as the current policy that only the very low income are eligible to get food incentives. Number 5 would be to anticipate outcomes. According to Burdock and Partashnik 2020, this must be included because that would increase the proposal acceptance. Because submitting a proposal without including the anticipated outcomes will increase proposal rejection, because they know a policy may not be implemented, and you give them a false pretense that it will. Step number 6 will be determine trade-offs, and such as in this case, it would decrease healthcare costs if more people eat healthier foods, such as fruits and vegetables and other plant foods like nuts and seeds. And also it would decrease hospital visits, and it would be a less burden on healthcare costs for the population and on the government level as well, who also pay the Medicare and Medicaid medical benefits. And after the 6 steps has been addressed, you want to pause, debrief, and focus on what the policy proposal really should be. And the last step is step number 8, is to narrate a scenario related to the issue. And I can use myself as an example that one day I came to work a couple of times and had seen my colleague was eating a fresh avocado. I never, and this is something that I never seen or tasted. And she offered the avocado to me as the incentive. And when I tasted it and I ate it with a piece of cracker, I really, really loved it. And after that, she bought a few more avocados for me, and then we eventually parted ways. And even after that, I started buying avocados and eat them all the time now. And then the greatest takeaway of that is that after researching its nutrition value, it stated that it has 1,000 milligrams of potassium, which is about a third of the recommended daily amount that you need. So I thought that was fascinating. So the second model is the Pender's model, and the rationale for that was to study health behavior. And as you can see here, you're going to see three columns. The first column is the cognitive perceptual factors, the second column is the modifying factors, and the third column is the participating in health promoting behavior column. And so the cognitive perceptual factors would be the population's importance of health, the population's perceived control of health, perceived self-efficacy, their definition of health, perceived health status, perceived benefits of promoting health behaviors, and their perceived barriers to promoting health behaviors. They will all be connected to their likelihood of engaging in health promoting behaviors by the cues of action. And then the second column demonstrates that their demographic characteristics, biological characteristics, interpersonal influences, situational factors, and behavior factors that could impact the cognitive perceptual factors. And according to Cotty-Disabati et al. 2022, this model was effective to evaluate behavior outcomes of health promotion. This last module here is the Rogers diffusion of innovation model. And the rationale for that was dissemination of the proposed policy. And for those who are not familiar with Everett Rogers, he grew up on a farm and later attended Iowa State University and studied agriculture and wrote a dissertation about it. And then he eventually wrote a book on diffusion of innovation, and then converted it into a 5-step model. And the first step would be to introduce the innovation by communicating the beneficial knowledge of the proposal, or the new proposal. And then the second step would be to persuade the stakeholders for the indications of the proposal. And step 3 would be allowing them to make a decision and give them time to make that decision. And then the implementation would be to allow time for the innovation. And then step number 5 is the confirmation for its effectiveness and outcome measures if the policy is implemented. The specific aims will be to review existing federal GusNIP policy outcomes data, to evaluate various state-level GusNIP criteria to reduce risk of bias in the federal or state GusNIP policy analysis focus, to compare effectiveness of incentives and disincentives, and advocate expansion of GusNIP for incomes above the federal poverty level. So the context was that combined incentives and disincentives effectively improved healthy behaviors for all populations. In the United States, 25% blacks, 36% Caucasians, and 17% Hispanics receive substandard nutrition. And the American Heart Association, the CDC, and the Dietary Guidelines for Americans supported accessible healthy diets from a variety of grocers and vendors. The intervention plan. The intervention plan would involve Burdick and Potashnick's eightfold path policy analysis, comparative analysis of qualitative and quantitative GusNIP data, and evaluation of current GusNIP policy guided by a proposed policy to be expanded to non-SNAP populations. Policy analysis. The policy analysis was the SWOT analysis, the strengths, weaknesses, opportunities, and threats. The internal factor was the multi-state GusNIP Interactive USA Map Tool. This map tool is interactive. When you visit the website, it displays a color-coded United States map, and you click on the state of your interest to see which program that funds that particular state. And you're going to see the states that are in gray do not have any food system programs for that particular year. And when you scroll down at the bottom of the page, it will display the program's links that you can click and find out more information about that link on the state level and the federal level. So the external factor was that no permissions were necessary to use this tool. Data validity and reliability involved using .org and .gov data and literature. That included peer-reviewed data and literature also. So this is the SWOT analysis broken down. The strengths are competencies and population norms and needs to apply suitable incentives. The weaknesses are improper nutrition and lack of food incentive policies for consumers. Opportunities are incentive policy change and improved marketing of plant foods. And threats are food choices, cultural preferences, and political issues. Measures. The Consolidated Health Economic Evaluation Reporting Standards is a guide for researchers and advocates to evaluate the economic consequences of the proposed policy and the current policy. And this, and known as CHEERS, it is created by the CHEERS task force and the Delphi panel of experts. The data requirements was using USDA publicized available data. The data collection process involved literature review, GusNIP summary reports, and a CHEERS checklist. That's embedded here on the slide, and the instructions for its availability is in the description box. The finalized measures were the analytic phase, which is the eightfold path that took about 6 months. If the policy would be implemented, that would take about 9 months using the Rogers model, and the timeline for those phases is about 15 months. Stakeholders assessment. The advocate should assess the stakeholders' acceptance of the policy change, assess policy knowledge, assess the stakeholders' advocacy capabilities, such as disability or time constraints, and assess their professional role identity, such as who will be the champions or the legislator for the new proposal. The analysis. The analysis plan involved the eightfold path, comparative analysis of federal and state level data, federal level food incentives analysis, state level food incentive analysis had determined the appropriate analysis focus. The state level analysis. Each U.S. state has various food programs. Each state has its own food incentive policy, and each state was awarded a different GusNIP grant amount in various times of the year and even consecutive years that created a challenge for state level analysis focused for the diet behavior outcomes. The federal level analysis, however, is that many states are funded by federal food programs such as Wholesome Wave Foundation and the Farmers Market Coalition. And as you can see, they are funded each one fund a certain amount of states. And the next analysis is that yes, the states are funded under different federal programs, and that's what determined the analysis focus on the federal level. And the benefit of this analysis is that the states, the multiple states, are within the same program. They are funded by the same program. However, the barrier is that it requires a vast amount of state analysis to saturate the data, because you still would need to create an analysis for one federal program at a time. But this project is still in its early stages of research, and the latter stages would require a deeper analysis that may also involve interviewing state level stakeholders, which can take many months or many years to complete the full analysis of this project. Ethical considerations. The academic institution of approval. The herb oversight was not required because no human subjects or animal subjects were used to collect the data. The confidentiality involved de-identified, publicized, available data. And if it gets to the point where a policy stakeholder will need to be contacted, they will be informed that the policy stakeholder information will be de-identified. Ethical considerations on the population level. Healthy food incentives are not applied to all at-risk populations with cardiovascular disease. Also, incentives are limited to very low income on the federal poverty line. Ethical considerations for disincentives may be questioned by even advocates for the policy proposal, and including questions from lobbyists. But excise tax reduces tobacco access for low income, justified by improved health. So though excise tobacco taxes reduces tobacco use access for the low income, that disincentive is justified by improved health, decreased hospital visits, reduced healthcare costs by the population and the government. On the same token, the healthy food incentives improve healthy behaviors, but the disincentives are unjustified for the low income. That is also justified by improved health, reduced healthcare costs for the population and for the federal government, according to Rapajal, Gopal et al. 2018. And therefore, food incentives and disincentives improved health behavior outcomes. Sustainability. Sustainability plan if the policy is enacted, will be the public stakeholder feedback and petition, and maintaining new policy exposure to the public. Because many people may not know that the new policy had existed. Just like the current laws that are enacted, many people do not know that these laws exist because of the lack or the very limited public exposure. Sustainability plan, if the policy is not enacted, would be using step 3 of Burdock and Potashnik's eightfold path, is to consider alternatives. And the alternative would be to convert this proposal into a continuing education credit course for the population and health and clinicians, and to continue public outreach, petitions, online seminars, webinars, and support groups to continue support to advocate the new policy. Dissemination plans of the findings would be submitting this proposal to a repository, a scientific journal, and converting the proposal into a smaller, condensed literature as the white paper that could be presented to the political stakeholders, policy legislators, champions, and the like. And this white paper will be available after reviewing the instructions in the description box. And the other plans for dissemination of findings would be submitting this proposal and this presentation to a learning management system such as CE Broker or HealthStream. And the final dissemination method would be social media such as YouTube, as you're reviewing it now. Conclusion. The findings stated that the lack of incentives reduced plant food intake and purchase versus applied incentives. Implications for practice is to educate stakeholders the importance of good nutrition and providing incentives to improve healthy behaviors. And continued research is needed to determine the outcomes for incentives as a universal approach versus individual state nutrition incentives. Further research and data are necessary for later stages of analysis and research. Thank you for watching this presentation, and please review all the instructions in the description box to access the embedded data and literature in this presentation.